You're watching BCTV, Branford's Community Access Station.
So we've come together to partner as a community. We started with 5 groups. The first Congregational Church with Betsy Dorsey and Margot Hardenberg. The Branford Community Foundation with an organization with Liza Petra. The Branford Counseling Committee, Community Services with Peter Samaro. And St. Stephen's, Amy Zion Church of Branford, and the Yale Center for Clinical Investigation with Tisha Johnson Harris, who has coordinated this wonderful gathering for all of us. And so we started out by talking about social determinants of health, and we were talking about a community that has been impacted by COVID in a disproportionate way. And we wanted to see if we could come together as a community to address the disparity. And so when we partnered with Yale, they were able to help us bring the Marcella Nunez-Smith and others as resources for us as a community. And so we targeted a condition that we think that's going to have an effect on us as a community in the fall, the flu. We also wanted to address with all of you, with the total community, the health disparities that exist and how they impact the health of all members of our community in one way or another. And so I'm grateful that so many of you have responded. I think it's wonderful for us as the community to come together. I'm like Dr. King, I'm happy tonight that we're all together on the same page, working for the good of our community. So I'm going to turn it back over to Tisha, who'll probably introduce our speaker.
Hi, so this is, as Reverend Perry said, the work is actually his brainchild, and he pulled together members of the Branford community who reached out to all of you for this special session. It's a pleasure to introduce you to my colleague and friend, Dr. Marcella Nunez-Smith. She is not only an expert in the space, she has taken care of me personally once at least in the hospital, so I can attest to her clinical skills as well. But Dr. Smith is a deputy director within the Yale Center for Clinical Investigations. She is the director of ERIC, our Equity Center here at Yale, and also assuming new responsibilities to really organize across the institution much of the community engaged activities of the medical school, the university, and the health system. So with that, I'm going to stop bragging on how wonderful she is and let you hear from her directly.
Good afternoon, everyone, and thank you so much, Tisha and Reverend Perry, for the introductions, but also just the opportunity to be in conversation with everyone today. So as was mentioned, my hope, I do have slides that I will share in a moment, but my hope is to begin to maybe create some context and just some shared language and shared knowledge around some of the challenges that we're facing with COVID-19, in particular when we talk about disparities and racial ethnic disparities, but also to highlight some opportunities where we can all sort of unite together in helping to protect our neighbors and help to protect, quite frankly, our healthcare system along the way. And I'm really just quite supportive of this conversation, of the role of protecting ourselves against influenza as a tool in fighting against COVID-19. So I will be looking for some confirmation from all of you that you can see these slides. Okay, great, and everybody can hear me all right. So just for the context setting and the conversation, we will sort of review our data around COVID-19 and its disproportionate impact, particularly in communities of color and the elderly. And we'll be thinking, of course, about sort of how do we situate disparities more broadly. Also, how can we be taking precautions ourselves? And then what really maybe is a way forward is as we head into flu season to be thinking about both of these viruses and what can be done really to keep our communities safe from these parallel threats. So I had an opportunity with a close colleague of mine at Yale, Carrie Gross, to do some research early on in the pandemic. Carrie raised this question, how are we doing with our national data on race, ethnicity, and in particular, are we looking at it the right way? He suggested that we should be taking an age-adjusted frame. People may or may not be aware, but in the United States, the populations of color on average are younger than white populations. And so it's perhaps insufficient to just look at raw numbers, but we should be thinking about for each age strata, kind of what are the disparities that might exist there. So these data were from in April. At this point, there were only 28 states and New York City who were even releasing data on race, ethnicity, and mortality from COVID-19. And we were quite frankly stunned at the time. This was, again, when data were just emerging, that there might be disparate impact on communities. And our analyses at that time found that for Blacks in the United States, the relative risk approached 4. That meant the risk of death was 4 times higher in that group. And for Latinx population, that number was 1.88. And so very high, very staggering, and showing that people of color were dying more often, but dying younger from COVID-19. So I'm often asked about the multifactorial contributions. Really, this is influenza, but it's COVID, and the point of today is that these really do overlap in terms of who is affected. We've had, I think, quite a vigorous conversation that's ongoing as a nation about the consequences and sequelae of structural disinvestment in communities of color and the intergenerational impact that has on people's economic opportunities as well as health attainment. And so that is, I think, part of our mosaic here as we think about these contributions is the role of racial injustice in our country. We also know there's been great misinformation, and this is why I think this group coming together is so powerful, because this is a group that can disseminate accurate information around COVID-19, around influenza. We also know that, understandably, from my perspective, there's an earned distrust in many communities of color when large institutions lead on messaging. And so we need to be aware of that. But one of the biggest drivers for why we see disparate impact for COVID-19 in communities of color, this is not an issue of biology or genetics, but really one of social context. And we know that for the groups that we've deemed essential frontline workers, there's an overrepresentation of people of color in those groups. And for them, it is impossible to work from home, and they need to leave their homes and put themselves at risk for what are typically very low wage, yet essential jobs. They are unable to socially distance at home and many at work, and many are unable to socially distance at home as well, where there might be households with multiple generations within them, and where the neighborhoods themselves may be densely populated. And in neighborhoods where the environmental exposures might be ones that over time have been very toxic producing and the air quality is lower. And you'll hear a lot about the greater burden of coexisting sort of preconditions that increase the risk of severity, such as underlying lung disease or heart disease, which is true, but we don't often speak as much as to the reality that everything I've mentioned so far contributes and drives to that disproportionate burden of those conditions. And then that's sort of paired with the reality that there's limited access to high quality healthcare in many communities of color. Many people of color are underinsured or uninsured. And I don't put forth this as an exhaustive list, but I think just important contextually. So I wanted to share with you, so Eric, Tisha mentioned, is a research center that I direct that's located at Yale. And we partnered in the beginning of May with the NAACP National Office, as well as the African American Research Collaborative, which is based out in New Haven and directed by Henry Fernandez, to conduct the first national poll of African Americans on the impact of COVID-19 on their lives. We were able to hear from over 600 respondents at the time. And so I will share a couple of our findings as we move forward in this conversation, but reminding us that this was early May, so still very different than things are now. This was before the murder of Mr. George Floyd, and things were actually different at the beginning of May when we first asked these questions. But even then, we found high numbers of respondents who were being hit economically by COVID-19. 40% had already lost their jobs or lost hours, and a full third of our respondents were already experiencing food insecurity. So I want to shift now. I have an opportunity to be in conversation with people about COVID-19 and groups about COVID-19. And I thought it might be helpful to share kind of some of the top 5 questions that I am most frequently asked when it comes to COVID. Right. So we're going to first talk about the signs and symptoms of infection with SARS-CoV-2. So the virus itself is SARS-CoV-2, and the clinical syndrome is COVID-19. Still lots of conversation about masks and face coverings that we can also have today. And then everyone is looking forward to some post-COVID-19 reality. And so often that conversation centers around when might there be a vaccination available to protect against infection from SARS-CoV-2. And really, for today's conversation, just some conversations around influenza, the influenza vaccine, and recommendations for vaccination. So the signs and symptoms, I am a practicing internal medicine clinician, and was working at Yale at the beginning of our search. And I know that just our thinking in the medical and clinical community has evolved so greatly in terms of how SARS-CoV-2 infection can present. So I think very early on, people would be able to name some of these symptoms: cough and fever, shortness of breath. As time evolved, we knew we needed to expand that presentation list. People can experience muscle aches, joint aches, even GI symptoms such as diarrhea, nausea, or vomiting. Fast forward a little bit more, we know that loss of smell, loss of taste can be pretty common. And particularly among older patients, the only presenting symptom might be one of confusion or fatigue. We also now know that among those in the 30s to 50s, the thromboembolic presentation, that is having a stroke, can actually be the presenting sign of infection with SARS-CoV-2. So the takeaway is that this is a highly variable clinical presentation. And so people with sort of a wide range of symptoms might indeed be infected with SARS-CoV-2. So we need to have a lower threshold for thinking about this diagnosis among our patients. Really important from a public health standpoint is that people can be asymptomatic, right? So there can be no symptoms at all and someone can be infected. And someone can be pre-symptomatic and be infectious. And so, in that window, before they themselves perhaps develop these symptoms we've talked about, can still spread the infection. So it really sort of begs this question that we need to do more in terms of prevention. And we need to get ahead on the messages that we as public health practitioners disseminate and share so people can really take care of themselves. So should you wear a mask? Should you have a face covering? The answer is a resounding yes. We know that this is really a harm reduction strategy. So this is about reducing the risk of infection. We don't have anything now that takes risk of infection to zero, but this does substantially reduce transmission. In addition to the other things you've heard about, such as being really vigilant with hand washing, trying to maintain social distancing. So importantly, the mask does not substitute for social distancing. So many people will say, well, we'll just wear a mask and then we can kind of have a party or a celebration, right? So we really need to still maintain social distancing and be intentional and conscious, always aware our bodies are in space, vis-a-vis others who may not be part of our quarantine household. Now, there's a lot out there in terms of what face masks and face coverings are effective. By and large, when I see folks with kind of the bandanas, that's not as good as having a face covering that is stronger, really. So we're looking for something that is a double layer, a triple layer of a tight cotton weave. Many have a filter pocket, which is also advisable. And that filter you can slip inside. It could be a household item. In my cloth face covering, for instance, I use an unscented dryer sheet in that filter pocket, and I change that out every time. Key to be sort of those cloth masks, when you remove them, to be washing your hands immediately after. To clean those cloth masks, these are not to be sort of used repeatedly without cleaning in between. So on hot water settings, removing that filter, using a new filter every time. And please, 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 to be effective, the face covering has to cover the nose and mouth. So I'm sure if I could see everybody, I'd ask for a show of hands for, as you move about the world yourself and in the grocery stores, how many people you see that have a mask kind of below their nose or maybe dangling from an ear or around their neck. That's not effective, right? So the best kind, what's the most effective face covering? The one that is worn appropriately is the most effective. So if you have one moment to talk to your neighbors and friends and family members about the face covering, I would use that moment to make sure that they have good technique for wearing it and for removing it. This is a little bit of a sidestep, but I think just context, because we are talking about disparities and we are talking about this disproportionate burden. In the poll that we conducted with NAACP, we asked about adherence to these same public health practices among our respondents. The dark blue is an always response. So we asked, from left to right about the frequency of hand washing, social distancing, not touching your nose and your face with unwashed hands, and the majority of people across all of these, including the last column, which is wearing a mask when outside, were adhering and working hard at adhering to these safety precautions. But we were very interested in looking more closely at the question of the mask and who's wearing it. We asked respondents, do you feel safe wearing a mask in public, for instance, in a store, or are you concerned that Black people wearing masks may be misinterpreted as a threat and that might put you at risk? And so perhaps we paused when we saw these findings, that a full quarter of our respondents who were aged 18 through to 34 felt unsafe wearing a mask in public because it felt that it made them a target for law enforcement. And I share this because I think it's really important for us to understand, both our messages. So when we tell people to stay home, yet there is no option for them because they're in a frontline essential job, or we say to wear a mask, but we don't acknowledge that may in fact cause people to have concern, we're not going to be effective. And so this was a tremendous insight, I think, for us. That work, again, was done in May, but then by June, there were stories emerging nationwide, as this shows, where there were Black men being stopped by law enforcement and others, specifically being told you're wearing a mask and therefore you're threatening. And this one story profiled the journey of a state senator in Illinois, who is a Black male, who himself was stopped because he was wearing a mask. And the title, I think, is very sobering, sort of which death do they choose? And just to help us to anchor some of this. I still, of course, even with that understanding, and I think that's nuanced and important, we really have to hold up the need for everyone to use face coverings. Keeping in mind, of course, that our risk of exposure is associated with both distance and time. So the closer you are to someone for a longer period of time, the higher the chance of infection. But certainly even at home, if someone has symptoms or known exposures or is concerned, wearing that mask at home around others is important. Keeping in mind, again, that your face covering is keeping you from infecting other people. And so as a community, we all need to wear the face coverings to keep us safe. So question number 3, when is there going to be a COVID-19 vaccine? There's lots and lots in the news, and we're all very optimistic. The timeline is certainly aggressive. I'm asked often about the risk of sort of shortcuts, and I do think it's important to reassure everyone that none of the safety standards have in any way been lessened at this time. It's just that we have an unprecedented sort of influx of resources to get the work done quicker. So to still have very much confidence in the vaccine development process. But still, my most optimistic estimate, is within 12 to 18 months, not of today. This is sort of dates us back to March, but still we need to keep in mind that it's not just the development of hopefully more than one vaccine, but we have to think about how to scale it up and mass produce it and distribute it. So as we talk a lot about herd immunity and how to make sure everyone has sort of developed these antibodies, that's still a little bit a ways away. We also have to think about vaccine confidence and the intention to vaccinate, and those rates in national studies so far are lower among people of color, around 30% in most national studies who express an intent to vaccinate. I will say that across the general public, it's about 50%. So we have a long way to go in terms of increasing vaccine confidence. So we've talked about various things, the harm reduction strategies until such time as there is a vaccine, the face coverings, limiting the gatherings, good hand hygiene. But really importantly, this year, more than any year before, universal influenza vaccination is a must. And we'll talk more about that, I know, today. Just a plug that I want to make, that I take this opportunity to do, which is, I know that there can be some confusion as to what services healthcare systems are providing, but healthcare systems are open, and we're open to meet all the needs of our patients. And so we sadly and tragically had people who were experiencing symptoms of heart attack or stroke or other things, and they did not come to the emergency department or seek help. And so we want to be sure to say that you can get care for anything you need at clinics, practices, and hospitals. They're all open for safe non-COVID care. So just the last few minutes to talk about influenza in particular. This, of course, is not new to us. Everyone here likely has personal experience with the flu. What's important to know is that that strain of influenza that is dominant does change from year to year. And teams of scientists, the expertise is trying to predict which strain will be most dominant, and then developing very far in advance, actually, the vaccination for the coming season. So we are heading up into flu season, which is important in the time of COVID. The flu vaccine, works similar to many of the COVID-19 vaccines that are in trial. The key is to get your body sort of exposed enough to create some antibodies and natural protection. So when it's exposed to the actual virus, it kind of has an army ready to go. Really important for people to know that vaccines are not designed to prevent one kind of catching a virus, whether it's a flu virus or SARS-CoV-2. It's really designed to minimize the severity of having contracted the virus. So people will tell me all the time, like, I got the flu vaccine, but I still got the flu. And I said, but you didn't end up in the hospital, did you? And so it's about the severity of it. I live with asthma. I have a son who lives with asthma. And when I've had the flu several times, but luckily I haven't had to go into the hospital or be placed in a breathing machine or anything else. And I think the vaccines are very effective in reducing severity from these. So there are a lot of parallels, of course. These are both viruses that do have a preference in many cases for the respiratory system. Coughing, sneezing, even just speech, singing will spread both. So it's really important that we think about I think now these parallel strategies. We're trying to preserve and protect the capacity in our healthcare system. We are typically overwhelmed in most years by flu. We just don't have, quite frankly, the luxury this year of dealing with both influenza and COVID-19 demands on our healthcare system. I think I can move forward. So as I alluded to before, we do see, unfortunately, both racial, ethnic, and socioeconomic disparities in terms of who is most severely affected by influenza. And so this is, just what you would say a perfect storm. The same groups that are at risk for poor outcomes from COVID-19 also at risk for poor outcomes from from influenza, both in terms of hospitalization as well as mortality. This shows that same point, just in a different visual and graphic, for some of the variation we might see by poverty and race, ethnicity across, and healthcare utilization as measured by hospitalization. So We know the CDC estimates are quite high. We are hopeful that this year, because we are also attuned to preventing the spread of respiratory viruses, that we might see a lower flu burden, but we shouldn't really leave that up to chance. We do know that there are many communities, those who are older, those living with pre-existing conditions, for whom the risks are even greater. And once again, we know that our resources are very tight in terms of our healthcare system, being able to respond to something like a surge event. So just a couple myths to dispel very quickly. So the flu vaccine does not give you the flu. I will say it again. So the flu vaccine cannot and does not give you the flu. This is perhaps the thing I hear most commonly from my patients is I got the flu vaccine and then I got the flu, I was sick for 2 days, right? So those are side effects. That's the vaccine working. It is very common for people to perhaps experience soreness at the site, to have a low grade fever, perhaps headache, even nausea or fatigue. That is your body kind of gearing up and making that army I talked about before. So it does not and cannot give you the flu. It really is for everybody. There are very few exceptions. And so everyone 6 months and older should really be getting vaccinated, particularly those who are pregnant and have medical conditions. And it should be taken annually. I think a lot of people, again, think that I had the flu shot 2 years ago and they mistake that with like a pneumonia vaccine that is on a every 5 year schedule. But for influenza, because the virus strain changes every year, you need to get vaccinated every year. You know, this week, there's sort of breaking news that getting the flu vaccine might even protect you against dementia, right? And might have protection against Alzheimer's. So we'll see if this bears out, but it's sort of intriguing, at least, to think that there might be benefits beyond flu protection from getting the vaccine. So similar to wearing a mask or a face covering, you know, you should get vaccinated for influenza. And I want to really stress that message. We are hoping to have vaccines available at a little bit of an earlier timeline this year than usual. So hopefully the end of August or September. But it is just imperative that we get out there and are proactive in making sure everyone is vaccinated. I had the pleasure of serving on the Governor's Reopen Connecticut Advisory Task Force. This is one of our major recommendations to everyone, is that we prioritize influenza immunization across all of our residents. Again, keeping in mind that we need to preserve our hospital beds should there be an additional surge. We know that we're working against this second phase potentially. We know that people are feeling a little bit more comfortable. Connecticut gets in the news every day for sort of low transmission rates. I know people are relaxing on their social distancing. We don't yet have the vaccine. And of course, we know that fall and winter are coming for influenza. So the need to vaccinate is just incredibly high. Many across the country are leaning in on this and highlighting that. So to prevent the spread of influenza and COVID-19, both wear the face coverings, wash your hands frequently, maintain physical distancing, be sure to cover coughs and sneezes, routinely clean objects in high traffic areas, and take care of yourself. Get adequate sleep, get some exercise, make sure you eat well, take multivitamins. And so I really do thank everyone for your time today. We are in a crisis. There isn't another way to describe that. And it's a crisis that doesn't affect everyone equally, but we are all in this together. And together we need to take adequate and appropriate precautions to keep ourselves safe, our loved ones safe, and our neighbors safe. So please keep the face coverings, get many in different styles, and also get the influenza vaccine this year. Thank you. Reverend Perry.
Oh, that's great. Thank you so much, Marcella. That's wonderful. I just want to say that as a follow-up, what we were trying to do in Branford was to see if we could not bring the flu vaccine to our communities of color, our elderly communities, our community as a whole. We were thinking of having spaces in either churches, community centers, or vans and toward the fall to help with this. And we were also asking Yale to give us support in terms of maybe making that vaccine available to everyone without cost if possible. So again, we want to thank you as always for your insightful
It is my pleasure. I'm happy, if there's time, of course, I'm happy to take questions or respond to comments.
There's a question. There is a question someone had. Where is it?
Tisha, we're not hearing you.
Marcella, you have a question in the chat. Do you think there will be shortages in the flu vaccine this year?
Yeah, thank you for that question. So I do, I am very optimistic because this was identified pretty early on as a need. And so there's been a ramp up in production and both in terms of volume, number of doses available, as well as thinking about getting it out earlier than normal. So I am actually remain quite optimistic that that we will have sufficient dosing. I will remind everyone, and these are conversations, of course, to continue to have with your providers, that there are different dose schedules and regimens. So, for example, those over 65, there's a bit of a higher dose to get to optimal protection than not. So, to keep some of those considerations in mind. But at the moment, the supply chain for the influenza vaccine is strong.
I also heard packaging shortages, packaging storage is hard to come by.
That might be a comment about the vials. And so I think that there was some questions about are there sort of sufficient vials? So my perspective is mostly from the state level where, again, in our conversations, the state feels very confident that we will have the doses needed for the residents of Connecticut. We do want, again, 100% uptake, which is not normally what we plan for. So, as people may well know, much of this ends up getting coordinated at the state level. And so the answers are more about the state response as opposed to the federal response, but for the state of Connecticut, the supply line is strong and not affected by the vial shortage.
Marcella, how important is it for people with pre-existing conditions to take the flu this year?
So I think this is the most important thing that people can do for their own health this year. I mean, short of the advice to, try to stay home and stay safe if you can, again, wearing a face covering is about our generosity for our neighbors, right? When we wear the face covering, we are keeping other people safe. What can you do for your own health is get the influenza vaccine. And most certainly from anyone who has a pre-existing condition. So, and the list is not a short one. So whether we're talking about having high blood pressure or having obesity or a heart condition or something like asthma, an underlying respiratory condition, it really is quite imperative for people to have the influenza vaccine. I briefly mentioned this, but for everyone on the call too, to be talking with their providers about whether they should have the pneumonia vaccine as well. So take care of yourself by getting the vaccinations this year. So yes, Reverend Perry, absolutely, yes.
Marcella, there was a question if you would share the reference about the potential dementia benefits so we can share that afterwards. One of the questions that also came in the chat, as Reverend Perry mentioned, the hope was to partner with the community of Branford to make sure that the vaccine is provided broadly to the community at locations where vulnerable community members might gather. And there was a question if we could have a bit of a conversation and some feedback from you and the community about that as a strategy, and whether you had suggestions for us as we begin to think about how to provide this activity. As an example, Reverend Perry is a member of what's called the Cultural Ambassadors for Clinical Research at Yale, which is a partnership between the AME Zion Churches of Connecticut and Junta for Progressive. Through that partnership, we've done pop-up vaccine clinics at the churches, at Junta in the past, and so our clinical staff come to the churches to do the vaccine, and they essentially bring the EPIC electronic medical record with them so that it's recorded as a clinical vaccination within the medical record and as part of the clinical vaccination strategy of that individual. So if there's any feedback, I see there's some in the chat, but you can also feel free to speak. You can use the raise your hand function or continue to type in the chat.
Can you hear me okay?
Yes,
Okay.
we can.
I'm sorry. This is Jamie Cosgrove. I do see that Rita Foster with East Shore District Health Department did respond in the chat regarding, and typically we do host some vaccination clinics here at Town Hall and some other locations, but I'm sure we can have a discussion, and I see Rita has offered, so we'd be happy to find out locations that would work for you. And it provided a number in there, but perhaps the town is willing to offer a location that may be ideal as well. I'm thinking especially with, I know we've in the past had clinics here at Town Hall, but given the current climate with social distancing, we may have to move that to a better location. I'm thinking right off the top of my head, maybe the community center where we can accommodate the crowds while maintaining social distancing. So we'll definitely work together on that. And I think not only identifying the locations, but I think what's probably of equal importance is getting the word out, right, in order to having that this is available.
Hi, it's Rita Foster. Thanks, Jamie. Definitely getting the word out is really important because I'm not sure who are your community leaders that would be able to spread the word for me. We do post all our public clinics, and maybe people aren't getting that message. So please call me or email me. I'll put my email in here as well to ensure that we get to everybody that needs it. And as Jamie said, it's going to be a little different this year because of COVID. We need like bigger spaces. We're looking to do outside events so that everybody doesn't have to be in the same space. So very happy to help. Thank you, Dr. Nunez-Smith, for this presentation. It was wonderful.
Thank you.
Thank you. I'll just respond quickly to you, Rita. I would love to follow up with you about that and how we can help share the information. The reason that we actually pulled together this group of leaders from the clergy and nonprofit and elected officials was to be able to begin to get the word out about both the importance of the flu vaccine as well as the locations and where we can provide it. So we certainly don't want to duplicate any efforts that you all are doing, but we would love to enhance and partner on how to educate and prepare. And one thing we've talked about is bringing the flu vaccine to people where they are to try to get over some of the obstacles that my new best friend Marcella mentioned around access to healthcare. So I really look forward to working with you, and I'm glad that you're on the call. Thank you.
Excellent. Thank you.
And just one other comment, we should probably give some maybe greater consideration to the times it's available. Maybe perhaps, whether it's extended hours into the evening or weekends, if that's possible.
Hi, it's Peter Semino, Branford Counseling. One of my concerns, as Liza said, is getting to people that can't have access to the sites we might develop. And I think that's going to be the important piece of the mobile. If we can get the mobile van getting to point A to point B. We have elderly housing complexes, and if we can't get people to a site, I think we need to go to them. I think it's really important that we get this done this year, because I think if COVID has another round with the flu, I think we're going to have major issues in this town that we have to try to avoid. So if we can put that into the plan, that'd be great, and we can identify some of those areas and go door to door if we have to. So it's something we should consider.
Hi, and this is Sue Lagarde from Shoreline Family Healthcare, which we opened literally 5 weeks before COVID struck. But we're there to help. We're doing pop-up testing these days. We are actually in Branford at one of the congregate housing units yesterday. We're happy to do, if anybody has would like us to show up anywhere, just give me a call and I can connect you. With respect to flu, we're similarly looking at the same thing. We can continue to do the flu vaccination either with testing or separate to testing. But the limitation for us is going to be just access to the vaccine. But I don't think that that's going to be difficult. I think the state's going to help us. We have a large volume of vaccines coming in that we've sort of earmarked for our patients. But anything above and beyond that, if we can get the vaccines, we're happy to run the clinics, administer, et cetera.
That's wonderful. Thank you so much. We'll definitely be following up with you about partnering on that.
I have one question. It seems as if, excuse me, right. We mentioned that there may be language differences among many peoples. And I wasn't sure if the community has figured out how to reach everybody in different languages. That needs to be.
I can say,
For Spanish, whenever we go out, we always have somebody who's bilingual in Spanish. Sometimes we do encounter other languages that we don't have on site. If we're really necessary, we have access to what they call a language line that we can always use. But it can be a challenge without question.
And I was just going to say that from an institutional perspective, that's one of the things that we have done with Reverend Perry and the ambassadors in the past. Marcella has language experts, and not only the translation of language itself, but also thinking about culturally appropriate language to make sure that there's uptake of the messaging and other things. And so really, Reverend Perry and all of the leaders that we've been speaking to, again, this isn't meant to be duplicative or to replace one of the efforts that you have going on. We just wanted to work together to figure out a way. As Marcella said, we're all in this together. The most important is to get all citizens the vaccine and access to it. And one of the other things that I will say, an important point, one of the goals of the Center for Clinical Investigation at Yale is to really oversee a lot of our clinical trials. Another important element of bringing the COVID vaccine forward is the ability of individuals, or the willingness of individuals, to participate in the clinical trials, to make sure that clinical trials participation is from diverse populations, so that we know as vaccines and other therapeutics are approved by the FDA, that diverse participation has happened. And so I think that's another important message. I know it's something that Reverend Perry and the ambassadors have been thinking about, but I think as a town, if you could also begin to think about those things. And I'm sorry, Robin, you had your hand up, and I think you're getting ready to speak. Please go ahead.
Well, thank you so much. Thank you, Dr. Nunez-Smith, for coming to Branford virtually here and offering all this great information. I serve as the state representative here in Branford, one of them, and we have had, as you may know, up in Hartford, I serve on the Public Health Committee, as does actually Representative Candelora. Vinny's on the call, I think, and we're serving. We've heard, as you know, significant sort of legislation that's come across our desks on immunizations and vaccinations, and the pushback that we have seen as a committee and as a state, and as we are hearing these concerns, how has that been either exacerbated by the COVID situation, or maybe patted down a little bit, or is it relatively the same? Can you discuss that?
Yeah, no, great. Thank you for that comment. And yes, so one of the things that I was just gonna mention is, it's just very wonderful to hear about all the work that's ongoing and the generosity of everyone to pitch in and help. And I think this is in many ways our practice for the vaccine distribution when it's available. And so to also kind of consider that and that kind of moment for learning opportunities for what does work well, maybe what doesn't, as we try to do sort of en masse influenza vaccination. So to take advantage of that from a learning opportunity, so we can strengthen our COVID-19 vaccine distribution networks when that becomes a reality. But the point you make is a very fair one. I quickly said it, but the national polling has really showed that across all Americans, kind of the level of vaccine confidence vis-a-vis COVID-19 is hovering around 50%. Right. And so, anyone will tell you that if we're aiming for like herd immunity, we need to get up 70, 80%. So if you have kind of 50% of Americans expressing some hesitancy and concern about COVID-19 vaccinations, that is something we have to activate around and be able to address. So I know that I get asked many questions. I know I've been asked in several sort of town hall settings whether schools will require influenza vaccination and COVID-19 vaccination. And so there are many parents who have questions and concerns that they raise. To Tisha's point, I think that it's imperative for the public health messaging to be very strong, that there aren't shortcuts being taken in the vaccine development process at all. When you hear in the news that it normally takes 5 years and so I think it's a very rational response to say, oh my goodness, they must be taking shortcuts, but we don't as often hold up the fact that this is everyone's full attention and all of the resources. So there's a great opportunity you've identified for us to strengthen the messaging vis-a-vis the safety, that the safety standards remain the same.
And I wasn't really just referring to the COVID.
To influenza even, yes.
Even to the influenza. I mean, that's one of the, probably the less used vaccination among folks, saying, well, I do all my other vaccinations, but I don't do that one. I think that we have an uphill battle with some of that work, and it will take all hands on
deck. Yeah, agreed.
There's another question. How does the medical profession distinguish between COVID-19 and one of the other cold diseases?
Yeah, perfect. So thank you for that question too. I think one of the slides showed that there's a great overlap in terms of the clinical syndromes. If we're talking about COVID-19 or influenza infection, the presentation might be exactly the same in terms of having fever and perhaps respiratory symptoms. And so, what is good is that we do have very strong diagnostics. So we've been able to test for influenza in particular and the different strains of influenza quite reliably for some time. And also here to say that I think we're making great strides in terms of the COVID testing, not just mostly around the ease of administration, right? Everybody here will be aware that many of the current tests require a lot of PPE demand on the part of the person who is administering the test, the nasal pharyngeal swab, and so it can, be able to move towards things like using saliva as the sample. So I think we're going to see more improvement that will make the testing even easier for COVID-19. So it's a great question. We feel like we do have the capacity to differentiate using these tests. But we also have a fair degree of confidence that one can be co-infected with influenza and with SARS-CoV-2. So just really, again, critical prevention is the best tool that we have in both of these conditions, is trying to prevent. So the public health messaging, the vaccinations, that's what we have to prioritize.
So, do you see the question? Can you address hydroxychloroquine as an option?
Yeah, so I thank you for raising that because, we often do talk about vaccines. There's a lot of work being done to identify therapeutics, right? So this is, back again to thinking about COVID-19. People are very optimistic that there might be therapies identified that might at least be life-preserving, so that if someone is infected and has a severe case, that it's important to say there is a wide spectrum, right? So we're most worried about the severe cases of COVID-19 that require hospitalization and intensive care treatment. The challenge is we can't always predict who might need that. So again, we need to keep everyone safe. So I too want to be very optimistic about treatment options, and there are some things. Remdesivir, for example, suggests that might shorten the length of stay in the ICU. So there are some promising things. We don't have an evidence base to support hydroxychloroquine for use in COVID-19. So I'm really glad to raise it because I think there are a lot of questions out there about that, but that evidence isn't there to suggest. But I know there are many colleagues at Yale who are working vigorously and trying to identify therapeutic options to help bridge until we have a vaccine, really looking at ones that might be life-preserving. So thanks for raising that.
I know that there's always, Marcella's done a number of these town halls. There are questions that generally come up after the town hall. Reverend Perry, Liza, Peter, Margot, Deb, I don't know if any of you as the group from Branford who actually organized this, if you want to make any closing comments, please do so at this time. This is your meeting. We're just the guests for, today.
Yes, thank you for having us.
Yes, I would like to thank you, Dr. Nunez-Smith, Ms. Johnson. Thank you very much for helping us organize this through the many weeks. And Reverend Perry, I really appreciate his interest in working with us. Thank you very much.
And I'll build off of that to thank everyone who's on the call for coming. I know this is a busy time and vacations, but it's really wonderful to see so many representatives from across the community who care about this issue and are committed to helping going forward. So thank you so much to our elected officials, to leaders of organizations, to leaders of the clergy. We are really grateful for your participation. Thank you very much.
Thank you. Yes.
Yeah, I would simply like to say thank you to everyone on this call. And this was not meant to be a one call, one town meeting. This is phase one of where we're going. And so phase two really has to do with getting the word out, getting the message out. And as leaders, we've got to find a way through publication, through our organizations, through our churches, to get the awareness to people and the information so that they'll have this information and then move toward the final step, which is implementation. But I think first it's important that we get the word out through our newspapers, our TVs, our pulpits, our community action agencies, and by word of mouth. And I think if we can do that, we can change the trajectory of how the outcomes in terms of people who will get this vaccination in the fall. So again, I just want to thank everybody. I want to thank Tisha, and I want to thank Yale. And I appreciate that now that you can say we're all partnering with Yale in this effort to change the outcomes in our community. And I think together we are stronger, and together we have a better chance of having greater outcomes. I thank our selectmen for being there with us, and for all of you who do this from your heart every day to try to make health awareness and health outcomes better for our community.
I'd just like to say one thing. I think as a community, when there's a crisis, the Branfords gets together and pulls together with a lot of resources, and this is a good example of this happening. And I think once we get it together and start getting the message out there, I think we're going to have a lot of safe people in town here. And I think that's the important piece, that everyone is going to be safe, and we're going to send the same message out all the time. until everybody gets inoculated and everybody is going to be a lot healthier. Thank you. Thank you all for showing up on this. Thank you.
Thank you. If you have any questions, Reverend Perry and Liza and others who communicated with you will have the addresses. We'll make sure to get the reference out. And part of this, we were asked to help with, developing messaging that we will be using here at Yale. Again, none of our efforts are meant to be duplicative of things that are going on in the town. So we're just happy to share any of the information that we've developed to help you in your efforts, or help message any of your efforts. So please let us know how we can be helpful, and your town leaders or religious leaders who contacted you for the meeting were a part of this planning. So I'm sure they would love to hear your ideas and thoughts. I think that was really the purpose of this meeting. So thank you all. And it was very nice to meet all of you virtually. Goodbye.
Thank you.
Be well, everybody.
Bye.